Well, the first step in treating any patient with atopic dermatitis is hydrating the skin. So patients like to bathe. We all like to bathe, and so do patients with atopic dermatitis. So we recommend that it's okay to bathe once a day, for instance, but it's so important when you finish your bath to apply a moisturizing agent, an emollient, before the skin really dries, to really try and hydrate the skin as much as possible. So we advise using these emollient agents often and very generously. There's really no danger from overusing emollient moisturizing agents. There are a variety of products that are available. The best functioning ones, the ones that do the best job in terms of hydrating the skin, are oils or ointments, but most patients don't like these. So we often settle for lotions or creams. But I think any of these would be reasonable, depending on what the patient preference is. The general recommendations are to use warm water, not necessarily hot water. Don't want to dry the skin out any more than we need to. Better to bathe than to shower. Only bathe for 5 to 10 minutes. Don't have a prolonged bath. And very important when you choose a soap or cleansing agent to avoid fragrances, to avoid strong soaps with agents like surfactants, for instance, that can really irritate the skin and perhaps aggravate the disease. So we really prefer non-soap cleansers in terms of what you use when you take a bath. And now bleach baths, as we already mentioned, are very important now standards of maintenance care for pediatric patients with moderate to severe atopic dermatitis. This may have an effect, as you mentioned, Amy, on reducing inflammation as well as preventing and treating infection. Well, what topical corticosteroids do we use? How do we select these? Of course, we recommend initiation of topical corticosteroids if intensive moisturizing or emollient treatment is not effective alone. And of course, we begin with a low-potency topical corticosteroid. We advise use of maintenance therapy to prevent exacerbations. If you're using a low-potency topical corticosteroid, you perhaps need to do this every day as opposed to a few times a week. Mm-hmm. You can also choose to use intermediate or high-potency topical corticosteroid, which would usually be a halogenated product. And this is very effective, as we said, for treating acute exacerbations if that's necessary. And can also be used as maintenance proactive therapy, but used less often, perhaps 2 to 3 times a week, as opposed to daily, because of concerns about potential adverse effects of chronic use of these stronger topical corticosteroids. Ultra-high potency topical corticosteroids are generally not used unless there's a very severe acute exacerbation, and we use these for very short periods of time. And we like to really avoid using these on the face where we know there's greater potential for absorption and skin changes in thin skin areas, such as the face and other skin fold areas.
So do you ever use a halogenated steroid on the face?
At times, I think we would use for a very severe exacerbation, and again for very short durations until we can get the inflammation in the skin under control and switch to a lower potency topical corticosteroid.
Yeah, I would agree. I think sometimes it can be very useful to just use for a few days,
yeah.
But the one area on the face I worry more about is that periorbital area because of the easy traversal through the lids, and we know of the dangers of steroids for the eye.
And we're concerned about skin atrophy, too.
Absolutely.
Yeah.
Now, I should add that one thing in my treatment regimen is aggressive therapy when I first meet children. Mm-hmm. So many of them come in and they've tried many different agents and aren't getting any better. And the first thing that I will do is I will hit them hard. Mm-hmm. And I'll have them go 2 weeks on non-facial areas with a class 2, pretty potent topical corticosteroid, and just knock it out. And on the face, I'll even go for a few days with that and then dial down to a lower strength topical steroid or a nonsteroidal agent. And I often find that the majority of these kids just get dramatically better. Some of them rarely have to use much after that from doing that more aggressive initial therapy. because this is such a process that cycles and gets exacerbated by not getting in there and treating aggressively.
And oral steroids are rarely needed for those severe exacerbations, but sometimes you do have to use them.
Well, I never use them in children.
Never use them in children. In adults, we do. So that's the name of the game, is to intensive therapy with twice daily application of a topical corticosteroid if you're treating acute atopic dermatitis until signs and symptoms are improved. And so that should be as long as it takes until you see resolution of the inflammation in the skin and the lesions for at least 3 to 4 days before dialing down on the dose. For repeated outbreaks that occur at the same type, of course, we already said that maintenance proactive therapy is a reasonable strategy. And you can use, for instance, an intermediate potency topical corticosteroid for 2 to 3 times per week in those areas you know that are problematic. And that's a reasonable thing to do as long-term maintenance therapy.
So that's particularly helpful, for example, for the child who has that recurrent antecubital or popliteal involvement, and the parents say every time we stop the steroid it comes back.
Right.
You can do the proactive therapy there, keeping it up 2 to 3 times weekly when it looks clear or almost clear, and they do pretty well.
Absolutely. So we also worry about adverse effects of topical corticosteroids, and we know that using higher potency topical corticosteroids can cause localized effects in the skin, and the common stigmata are stria, or you can get, unfortunately in time, skin atrophy if you're not careful. Periorbital dermatitis, as Amy already mentioned. Rosacea can be a complication. And of course, allergic contact dermatitis if our patients become sensitized to the corticosteroid itself or an additive in the products. We have to be careful if they're not getting better, and as we might expect, it may be due to the fact that they have an allergy to something we're giving them. So that could be an iatrogenic factor that may make things worse. Systemic use of steroids, we know that we don't necessarily recommend that, particularly in children. But we do know that there can be systemic corticosteroid effects with prolonged use, and we occasionally are concerned about the risk of adrenal suppression, particularly in younger children, where this can be a problem if you use a higher potency or medium potency topical corticosteroid on a long-term basis. But this is relatively a rare event that we see in clinical practice.
And I think this is really important to stress that so many parents come in with steroid phobia. And in fact, a lot of doctors have steroid phobia as well and perpetuate this by telling families to limit the use to just a few days and of the dangers of topical steroids. It should really be stressed that when used properly, it's really quite unusual to even see the local side effects like thinning of skin, let alone anything systemic. This is really an important piece of our regimen in care. And if the parents are so worried about the risks of steroid that they're not using them and using them appropriately, the children risk not getting better. And that impact of not getting better on their quality of life is so much greater than the risk of the local or certainly systemic effects of the use of the topical agents.
Very important, very important.
So let's move on to talk about nonsteroidals. We do have some options. And the topical calcineurin inhibitors came out more than 15 years ago now in 2 flavors. We've either got a pimecrolimus cream or we've got a tacrolimus ointment in 2 different strengths. And these are shown to block pro-inflammatory cytokine expression and not to have some of the other potential risks of topical steroids. They don't have atrophogenic properties, for example. And they've actually been shown when used for more maintenance therapy to reverse some of the steroid-induced atrophy if it occurred. So they are steroid sparing and particularly important for sensitive areas like the face, the genital area. And the biggest problem with getting them is that access has been more of an issue. The topical corticosteroids are still considerably less costly and easier to obtain through prescription. Now, for the topical calcineurin inhibitors, twice daily application is recommended. One can also use the topical calcineurin inhibitors for proactive therapy, just as we talked about before, putting this on 2 to 3 times weekly on those areas that recurrently flare. Yeah. After getting it into control with possibly either twice daily use of the topical calcineurin inhibitors or more commonly with the topical corticosteroids. And the only thing we really see with the topical calcineurin inhibitors are local effects like stinging and burning. In fact, this particularly occurs when you're using it on very inflamed lesions. I'll commonly calm things down with the topical steroid, and then if I'm going to use a calcineurin inhibitor, I will switch over to that because that markedly reduces the risk of having stinging or burning when you're applying it. Now, back in 2006, a black box warning was applied to this whole group of topical calcineurin inhibitors. It was the first time a theoretical risk had led to putting on a black box warning, and was done because of the known problems with systemically administered tacrolimus for transplant patients, and some very, very high dose studies in primates that were done preclinically. I'm relieved to say that in the last 15 years there's been absolutely no evidence of an increased risk of malignancy, but should mention that that black box warning still is there, which means that pharmacists have to tell parents about the potential risk. So very important for doctors in the office when prescribing these to take one extra minute to warn about the fact that they may hear about the potential increased risk of malignancy, but to reassure that there's absolutely no evidence of this clinically. I also want to mention that we have a new topical inhibitor that is not steroidal and has just come on the market, and that's something called crisaborole. Crisaborole is a phosphodiesterase 4 inhibitor for mild to moderate atopic dermatitis as young as 2 years of age, and we'll talk about that more to come.
Well, we also have other potential options if a patient's not responding to the modalities we already described, that is moisturizing agents and topical corticosteroids. There have been a lot of popular sort of preparations that have been used over the years, including tar preparations, which themselves may be beneficial in some patients, but not very pleasing. Most patients don't like the aesthetic parts of using tar on their scalp, for instance, and tar shampoo. There are topical antihistamines which have been advocated, but there's no good evidence to support the use of topical antihistamines in controlling the itch of atopic dermatitis, and they have the potential to cause sensitization and contact dermatitis. So we generally avoid using topical antihistamines in our patients. Again, for topical antimicrobial agents, although this was a widely practiced option, now looking at the evidence, there doesn't seem to be any good evidence suggesting that chronic use of topical antimicrobials are effective in controlling atopic dermatitis or even preventing necessarily infections. We do sometimes use antiseptic dilute bleach baths, as we already mentioned, which could be classified as an antimicrobial approach, but not an antibiotic by any means.
And since you mentioned the topical antihistamines, we should add about the oral antihistamines, which, of course, non-sedating are commonly used for allergies, and many of these children have that. But the sedating antihistamines can be very helpful at night because of their sleep-inducing effect. We can still see the kids scratching actively. It doesn't really take away the itch, but they do need their sleep, and sometimes that can be very helpful when used in high doses that make them sleepy, but don't make them so sleepy that they can't go to school the next day.
You're talking about the first generation antihistamines.
Exactly.
Say hydroxyzine or diphenhydramine or something of that sort.
Yes, and we should also mention that those are in different classes of antihistamines, so they can be used concurrently or serially during the night if needed.
Okay. Well, we also need to talk about the importance of being aware of triggering factors in atopic dermatitis. And sometimes we really lose sight of this, that some of the best ways to really control and prevent flares of the disease and to help control the disease is, again, to pay attention. And every time you see the patient at a visit, ask whether they're using soaps or detergents to bathe themselves, which can certainly irritate and aggravate their condition. We generally advise against wearing wool or occlusive fabrics. And again, we already mentioned the potential for contact allergens. We have to really pay attention to what they're putting on their skin. A lot of times there are fragrances in some of the emollient products even that can be sensitizing. And also now with the natural products on the market, there's a lot of botanicals. These are flower or tree extracts, which themselves can be very sensitizing and really cause a real problem beyond what we're dealing with, the patient's atopic dermatitis. Really very important to make sure that the patient isn't in a low humidity environment as much as possible. So reduce exposure to cold and things like that if possible. We also, if relevant, would recommend that they avoid allergen triggers if we're able to document, for instance, that during a pollen season, for instance, they have atopic dermatitis that flares. At least need to be aware of that. I'm not sure we can actually prevent it, but we know it's coming and we can treat it during the season. And skin testing may actually give us some insight in terms of what are the important allergen triggers. Now, there has been a number of studies which have examined the use of allergen immunotherapy like we use for treating allergic rhinitis or asthma and its impact on atopic dermatitis. There has been a meta-analysis and put together several studies suggesting that patients, adult patients particularly, with house dust mite allergy may actually benefit from allergen immunotherapy. It's important to select the patient carefully and to make a determination as to whether house dust exposure does aggravate their condition. But personally, we have seen some positive results in such patients. We talk about leukotriene inhibitors, which we use for other allergic diseases like asthma, allergic rhinitis. There really hasn't been any data showing that these are effective in managing atopic dermatitis.
We can't talk about management without talking about education. And of course, education is very important if you want your patient to follow the regimen that you've prescribed. So we talk to the patient and the family about the chronicity of atopic dermatitis, about exacerbating factors, and about the efficacy and safety of various treatments. But it's important to try to demonstrate skincare techniques, and really important to send families home with a written treatment plan. We all know how we listen to what we're told and promptly can forget when we get home. Now we have electronic medical records. It's so easy to be able to send home something that someone will have in front of them to remind them of what we said. There are situations where we may want to refer, whether that's to an allergist or whether that's to a dermatologist or a specialist as needed, depending on the complexity. And also it's very important to let patients know about support organizations like the National Eczema Association, very helpful with educational materials online. It's always important as well to spend a little time talking about the impact of the disease on the patient and the family. You mentioned before how important it is to ask about the itch and the sleep and the restrictions that the disease has caused. And sometimes one can just discover, for example, that there are psychological impacts, and that can be very helpful to address that and to get additional intervention from specialists in that as well. We sometimes think about itch and sleeping issues and again get referral to specialists who can help with that in addition to the interventions that we can move forward with.